So the rationale for the peri-transplant Rux study originated from an initial study I did opened in 2014 with pre-transplant only Rux. In the past, the non-relapse mortality for patients with myelofibrosis, at least at our center, had been around 30%. And with the approval of JAK inhibitors, we hypothesized that patients who had spleen response and symptom response would have improved response post-transplant because of improved performance status and engraftment. So we, in that study, administered ruxolitinib for at least 8 weeks prior to transplant and improved survival by 20% and decreased non-relapse mortality down from 30% to about 12%. But patients still had 71% incidence of acute graft-versus-host disease and 55% chronic, with 44% of that being moderate to severe. And that was published in the TCT journal. So the next step I thought after the approval of ruxolitinib for the treatment of acute and chronic graft-versus-host disease was to continue it through transplant for prevention. And so in this study, we required patients to receive at least 8 weeks, but continue through transplant and then receive ruxolitinib for at least 9 months. So at least 2 months after stopping tacrolimus. And we did note in the study almost identical non-relapse mortality, though the 1 year was only 2.5%. And the graft-versus-host disease incidence was only 27% acute, with about 10% chronic and almost no mild to severe, about 5%. So we've seen great improvements with the peri-transplant Rux platform at our center. And I wouldn't say it's the standard of care for us at this point, but we have a follow-up study now looking at patients with mismatched donors, antigen mismatched donors, and overlap syndromes. That's going to further expand that platform.